It's wonderful to have all of you here for today or this evening or this afternoon, wherever you are, our town hall style webinar on genetics and the Promise Registry. This event is brought to you by Xero, the End of Prostate Cancer. And we are so happy to have these partnerships with Myriad Genetics and the Promise Registry. My name is Shelby Monier, Vice President of Patient Programs and Education here at Xero, and I will be your host and moderator tonight. For those of you not already familiar with Xero, Xero is the leading national nonprofit with the mission to end prostate cancer and help all who are impacted. Xero advances research, provides support, and creates solutions to achieve health equity to meet the most critical needs of our community. We offer an extensive portfolio of patient programs, patient support, educational tools. All of these are offered at no cost to patients and families. So really want to make sure that you or someone you know, if you are in need of these types of resources at any time during this prostate cancer diagnosis, please reach out to us, share these resources, and just know that you are not alone, and Xero is here to help. So we're really excited. We love these town hall style webinars. They're highly interactive. They lead to really great discussions. Our constituents, our patients, and our attendees learn so much. So we're really excited that you're here. To our attendees, please drop any questions or comments into the Q&A box. If you're listening on Facebook, drop a comment in. We're moderating all of these, and our team will get them to me, and I'll get them to Rob and Dr. Pollard, who I'll introduce in just a moment. So if you miss anything during this conversation, we are recording this event. It'll be posted on our website, which is xerocancer.org tomorrow. And you'll also receive it in some emails after the event. So after the town hall concludes, you'll also see a link to a survey. We really would value your input on that survey. It helps us build better, stronger events like this and tackle topics that you want to hear about in the future. So please let us know what you think of this event so that we can meet your needs. Tomorrow, you'll also receive an email with a link to both the recording and a friendly reminder to participate in the survey once more. So with that, I want to thank you again, Myriad Genetics and the Promise Study Registry, for your continued support. And I want to point out, while this town hall webinar, I know it's got a lot of names, but is sponsored by both Myriad Genetics and Promise, there's actually no commercial tie between the two. So we really value the partnerships of all of our sponsors and partners, because it enables us to bring really unbiased and helpful information into the hands and eyes and ears of the patients and community in the best way possible. So really quickly, I also want to tell Rob, Dr. Pollard, how grateful we are to have you both spending your evenings with us. So thank you for your expertise tonight. But speaking of our speakers, let's just get right into our introductions. And I'm going to keep these short. I know if you've registered for this webinar, you've seen the full bios, but Dr. Channing Pollard is Associate Professor of Oncology and Urology at Johns Hopkins University, Sidney Kimmel Comprehensive Cancer Center, and Associate Director for Oncology of the Johns Hopkins Clinical Research Network. Dr. Pollard is lead investigator of Promise Registry and an expert in clinical trial design, leading multiple clinical trials with innovative new treatments and treatment combinations, employing germline and somatic biomarkers. So we're thrilled to have you, Dr. Pollard. And Rob Finch, both of you have also been here with us before, so we're very excited to have you again with us. Rob Finch is a certified genetic counselor and Director of Urology Medical Affairs at Myriad Genetics. And Rob works to educate and provide clinical support to healthcare providers who treat prostate cancer for Myriad's array of tests, but BRCA analysis, CDX, MyRisk hereditary cancer test, and Polaris. So just again, thank you. I know that was fast, so we want to dive right in. So thank you both very much for being here.
Happy to be here. Thanks.
Thank you, Rob. All right, well, let's get started. We want to keep things moving. We have a lot of questions. We were actually able to gather 20 or 25 questions from all of our amazing participants. So let's start from the basics, and we'll work really high level and then kind of get a little bit more specific. And again, this is a very free-flowing conversation. So Rob, if I ask you a question and Dr. Poller, you have something to chime in on and vice versa, please do that. We'll most likely interrupt each other a couple of times and talk over each other, but I'll try to zip it as much as I can and go on mute because people are not here to listen to me. So I want to hear from you, and so do all of our participants. But before we jump into Promise, Dr. Poller, let's start very high level, the absolute basics, and set the stage for our conversation on genetics. So can you help us understand and just be very clear on the differences between genetic testing, which we're talking about here, and genomic testing in prostate cancer?
The Promise study is focused mostly on inherited cancers. And so that's what you inherit, or your genetic DNA from your family members. And so that's really what we're focused on. We're not focused on genomic changes that can happen during your lifetime as your cancer develops and makes mutations, or as, for example, if you go out in the sun and get a sunburn this summer, right, your cells may mutate and develop new mutations. That's not inherited. That's sort of the somatic changes that happen over time. And so Promise is only what you inherited from your mom and your dad. Rob, do you want to add to that?
Sure. I was just going to say that genomics and genetics are often used interchangeably. And so, for good reason, there's a lot of misunderstanding. There's a lot of confusion. So basically, when we think of genomic tests, we're looking at tests on the tumor itself. And so there are several different tumor biomarkers that are out there. We have one called Polaris. There are other laboratories that have them as well, that look at the tumor to see how aggressive the tumor is going to be. And then, like Dr. Poller said, there's the germline, or the genetic test that we, looks at the genes that we inherit from our mom and our dad. Several labs, again, out there that do the testing. We do have the BRCA-analysis CDX, which is the only FDA-approved germline genetic test, as well as the MyRisk test, which is both of them together are about 48 different genes. But again, there are other laboratories that offer testing as well.
Great, thank you. So, Dr. Poller, why should we care about this? Why are our genes so important when it comes to understanding prostate cancer treatment and outcomes?
Well, prostate cancer has undergone a revolution. There was only one drug back in 2004, and it was just chemotherapy, a toxic chemical, when I first started being interested in this field. And since then, we've come up with over 10 drugs to treat prostate cancer, 3 of which are for targeted therapies for somatic or genomic or genetic mutations that we can target to harness the cancer. And so there's now 3 FDA-approved drugs, and there's also clinical trials where we can move these drugs earlier. So I have a patient who's been on olaparib, a PARP inhibitor, for 3 years with no hormone therapy. And he is one of the most excited men I know, right? To avoid the side effects of hormone therapy and control his cancer for 3 years, that's pretty exciting on a clinical trial. And so it's really important for standard of care, for moving the field forward, that we learn these biomarkers and learn how to target the cancer. I think a lot of other cancers are ahead of us, and prostate cancer is finally catching up. It's pretty exciting.
Yeah, that's amazing. And I think we all want to see this disease, if it's not going to disappear entirely, at least turn it into a chronic, manageable disease with as minimal side effects as possible. That's great news to hear about that patient. That's wonderful. So Rob, what can our DNA tell us about our family risk for prostate cancer? How do those conversations normally go? I mean, you're a certified genetic counselor. Tell us a little bit about those types of conversations that you have with people.
Sure. So, the majority of cancer is not hereditary. That's what I always start with, is that, the chances of someone having a germline mutation, it's about 1 in 7, about up to 17% we've seen in the literature. So it's not negligible, but it's not everybody. We're all at increased risk for anything found in our family. So if we have heart disease or diabetes or anything, we're at risk for that. However, that's sort of a different category that we call call familial. And then the hereditary is where we can actually look at genes and see whether there's a mutation in the gene or not. Did I answer the question, or did I sort of?
No,
Okay.
That's great. You know what? If you don't answer, I'll just ask again in a different way later. we have a lot of questions, so no, I appreciate that. Well, really quickly, before we jump in to learn a little bit more about the details of Promise, Rob, and you did this a little bit when you answered that first question, but give us just a little bit of an elevator pitch for Myriad Genetics. You mentioned the tests that you guys have available, but spend another minute talking about the differences of those tests and which ones prostate cancer patients might be interested in.
Sure. So we have the Polaris test, which again looks at the tumor itself, looks at what we call the cell cycle progression genes, which is a lot of confusing words, but it looks at basically how fast the tumor is growing and how fast it's spreading. A lot of men with prostate cancer is growing very, very slowly. And so you don't necessarily have to do anything right up front. You can wait and watch it. However, there are some cancers that do grow more quickly and are more aggressive. And so Polaris is one of the tests that can help us see, is this a slow growing cancer versus a fast growing cancer? Then looking at the germline test, we do have the BRCA analysis CDX. As I said, it's the only germline FDA approved genetic test for PARP inhibitors. And that was because we've been involved with a lot of the PARP inhibitor studies in ovarian cancer and breast cancer and pancreatic cancer, and now in prostate cancer. And then we round out the rest of the panel. We have the MyRisk panel, which is a total of 48 genes that look at genes that are important across a lot of different cancers.
Great, thank you. So when you're wearing your certified genetic counselor hat, is genetic testing for everyone? When you're talking with someone who's considering it, how do those types of conversations go?
Yeah, so, back in the beginning, I used to see patients up at Memorial Sloan Kettering in New York, and we would have to take family histories of four separate generations, and they used to need to have a lot of cancer in the family, and those criteria have loosened a lot over the years, to the point where now anyone with ovarian cancer can get germline genetic testing, anybody with breast cancer, anybody with pancreatic cancer, and now prostate cancer is getting there as well, where it's important enough to know this information that pretty much anybody with prostate cancer can get a germline genetic test.
So that leads me into one more question I want to ask you about timing. Is when should someone start thinking about genetic testing? Is it only after someone else they know and their family has been diagnosed? Is it more of a precautionary type test? Share your thoughts on timing.
Sure. So when we're talking about the genes that we inherit from mom and dad, we have those our entire life, from the time that we're conceived to the time that we die. And so at any point in that period, if there's even if you don't have cancer and there's a lot of family history, that can be a time to decide about genetic testing. Once you've been diagnosed with cancer, at diagnosis, that's a good time to consider genetic testing. If you've had prostate cancer, it's been treated, you're 10 years out, you're 15 years out, because those genes don't change, really at any point, you can do genetic testing. You only need to do it once, but at any point during that prostate cancer journey.
Great, thank you. All right, Dr. Powler, let's dive in and learn about Promise specifically. So kind of getting back to the basics, let's start broad, and let's just talk about what the heck a registry is. What does that even mean?
So Promise is distinguished as a registry as opposed to a standard clinical trial, because we're not giving a drug, we're not sort of doing an experiment, we're just gathering data. We're a repository where we are screening 5,000 men for free with free genetic testing, and 500 of those we're aiming for to either have variants of uncertain significance or pathogenic mutations. And then my co-PI and I, Heather Chang, are going to put our arms around those 500 men and follow them for 20 years and say, hey, let's learn more about these rare mutations. Let's help those men know the standard of care that's been approved by the FDA. Let's help those men find clinical trials that they want to find. Let's be their advocates. And in return, those men are going to, confidentially provide information about how people do with certain mutations. Learn more about BRCA2, learn more about ATM, learn more about various rare mutations that we don't know as much about. And so we're going to follow these men and sort of nurture them over time and grow together and be a community.
That's wonderful. So of the 500 you're hoping to enroll, what are the current numbers?
Well, so we've screened almost 1,500 people already, and we're approaching, about 100 that are eligible. And so we think this will take a couple more years to finish accruing. And then we'll have all of the people in the cohort. We may expand. This may become a very important way to match people to clinical trials. It still saddens me that nationally 5% of adults go in clinical trials and 50% of kids go in clinical trials. At an academic institution like Hopkins, it's more like 20% or 25%. But I would love it if everybody got the opportunity to choose standard of care or standard of care plus, right? And got to learn about these opportunities to really get personalized therapy for their treatment.
Yeah, absolutely. And we talked a little bit about this in the brief intro, but and you mentioned the difference. This is not a clinical trial. You're not giving treatment. You're not giving treatment advice. But how is the Promise Registry different? And who sponsors it? Where do the funds come from?
Right. So this is really special that it's not sponsored by a pharmaceutical company. And the company providing the genetic testing, Color, is doing it because we're paying them to do it. So the foundation is called Advancing Cancer Treatment. They are a nonprofit. It has patient advocates, sort of people supporting them, but it is no drug company, no pharma company, no any company involved in it. And Heather Chang and I felt pretty strongly about that because we didn't want it to be biased. We really want it to be a collaboration between patients, caregivers, family members who are going to find out about inherited cancers, researchers, just a community of we're all in it for the same purpose.
Yeah, wonderful. Well, I love what I know about Promise in that the follow-up is so wonderful. I think, am I correct in saying that there's follow-up about every 6 months with patients who become enrolled?
Every 6 months, we ask you how you're doing, a quick short survey of sort of patient-reported outcomes. And then every 6 months, we ask medical records at your doctor's office to send updates on changes, new treatments, how you're doing. So it's supposed to be pretty easy and yet high yield so that we can educate each other and the community. And the 5,000 people who sign up, or the 4,500 who aren't eligible, they can sort of follow along. They're not going to get privileged information, but they can learn as new treatments come out. They can see the website to see clinical trials. Maybe, for example, they develop a mutation that was not inherited, but they develop a mutation. They still could be eligible for one of those trials, and they could learn about it at the Promise website.
Great. And we're dropping these in the comments, the websites for everyone. So you mentioned the eligibility. Dive in a little bit deeper on who is eligible and when. Does that have anything to do with a current treatment or when the patient has been diagnosed? But if you could expand on the eligibility, that would be great.
Sure. So what's pretty neat is I'm starting to hear rumors about only this group or only this group. And that's because there's so many groups promoting it for their little subgroup, which is wonderful, but because it's a free resource, right? But it's anybody over the age of 18 with a diagnosis of prostate cancer by biopsy or because your PSA was once over 100. So you could have been treated, you could be in active surveillance, you could have metastatic cancer. Anybody who has a known diagnosis at any point in your lifetime of prostate cancer, you are eligible. And even if you got Myriad, even if you got Invitae and you have a mutation, I want you even more. I want to hang out with you. I want to help you. I want you to help us in the community and future patients. And so please consider signing up.
Can I interject that's so important,
Rob,
because as a commercial laboratory, we do not share information. We know information about you at the time that the test is ordered because we have to use that in order to get insurance coverage, et cetera. But research is so important because we don't share that information with pharma companies, with registries, et cetera. And so it's important that if you want to help advance science, that you do take part in some of these research studies and registries.
Yeah, no, thank you so much, Rob. That's a great point. And we get questions at Xero about trust and medical distrust, and how are my medical records being protected, and how can I trust that I'm going to take a saliva sample and put it in the mail? How do I trust that that is a safe thing to do? So I would love for you both to talk a little bit more about how medical records are protected, and how you work on the privacy for the patient. That would be great if you could keep expanding on that.
Absolutely. We felt really strongly about it, and that is why no drug companies or any companies are involved. So it is me, and I don't even see the details. The study coordinator does, Heather Chang, and the Prostate Cancer Consortium at Sloan Kettering that sort of helps fuse it together. And then everything is confidential, HIPAA. Nobody even needs to know anything except you and the Promise Registry. And we really de-identify data when we put it in so that your information cannot be stolen or shared, or it will not harm future jobs or insurance or anything. And so this is really a safe space to learn together and improve the care for prostate cancer patients.
Great. Thanks. Rob, did you have anything else? I know you kind of brought up the privacy, so I don't
have that much to add, just to say that we only give results to the physician who has ordered the test. If a patient would happen to call us and want their results, we don't even give it to the patient unless their physician has already seen it. And so, we just believe in the privacy of genetic information as well, all around, all of us.
Yeah. And I would say we're different in that way. We only give it to the patient and a physician of their choice or not.
Okay.
It is your information and only yours, and you're allowed to do with it as you please.
Yeah, well, and those are just highlighting the differences in how people find out about genetic testing and want to get involved. So I think, those are great points. Rob, I think, well, actually, no, I can't remember who mentioned it, but we were talking. I know with the two people, it's really hard to keep up. How we talked a little bit about just benefits of participating in research and benefits of finding out more about your particular disease. We know, especially in prostate cancer, this is not a one size fits all disease. It's not where we can't treat every patient the same. All of the diagnoses are different, but talk a little bit more about reasons that patients might want to get genetic testing, and also reasons why patients might want to participate in research.
Sure. So reasons why patients might want to get genetic testing, first of all, because it helps them learn more about their own cancer diagnosis, whether it was hereditary or not. There are certain genes that do increase the risk for second cancers. So for men who have prostate cancer and do well on the prostate cancer, if they have a BRCA2 mutation, for instance, they need to know that they might be at a slightly increased risk for male breast cancer, things like that. But also for family members, we can't forget our family members. And so sons, daughters, siblings, anybody who is related to someone who has a germline mutation is also at risk to carry the same mutation.
Yeah, I feel like if we don't do research, we're just going to keep doing the same thing we do every day. Mm-hmm. So I feel like research are the drugs of the future. Research is the way that we treat people and understand genes, right? Maybe we think a gene's scary and bad, and it turns out it was really nothing. And maybe we think a gene's innocent, and it turns out to be super bad, and we have a target, and we can keep you alive and make prostate cancer a chronic disease. And so I think being involved in research is critical for patients themselves and for the future patients. So I honor everyone and appreciate everyone who's involved.
Yeah, and Dr. Fowler, you made a great point at the beginning of our discussion, and that chemo was it. That was it. In 2004, is that what you said? And look where we are now. I think more than 35 approved treatments, if I'm not mistaken, and all of those are made possible because of research and clinical trial participants. So very important. I used to know the stats off the top of my head, and I don't anymore, but also worth mentioning, really, really high satisfaction rates for patients who participate in. And I know the Promise is not a clinical trial per se, but really good feedback and when patients do participate in research, they're often very, very pleased that they've done that and feel like they're giving back.
It's nice to have partners. You get extra attention. Bill Nelson, our head of the cancer center, used to say to me, he's like, yeah, you get as good or better care. They get all extra touches, all their questions answered, any drug interactions. I mean, it's just like your personal doctor and nurse and pharmacist on call 24/7. It's kind of nice.
Right. Yeah. Well, yeah. Go ahead, Rob. Sorry.
No, I was just laughing.
Well, Dr. Peller said she likes to wrap her arms around you. So that's a great example, right? Well, wonderful. So, and I think you mentioned this already, but Dr. Peller, talk for another minute, if you don't mind, on the commitment to participating in Promise and then just how someone joins.
Right. So you can do it. It's COVID friendly from your couch. It's free. You don't have to have an income. And you just have to have a place where the mail can be delivered to a friend's house. I don't care. And you send in your saliva sample. I always say 4 to 6 weeks, but I was on a support group call earlier today, and they told me they all got it back in 2 weeks, and I was very impressed. And so you get it back, and then you set up an appointment to go over it with a genetic counselor who can go over your risk, your treatment opportunities, and potential trials, and then also your family's risk, right? Do you have to screen your daughters or sons for certain cancers that may be associated with those genes? What's really nice is when we negotiated the deal with Color, it wasn't just about prostate cancer. We actually did the whole 30 gene panel. And so although we're focused on prostate cancer, you get the whole official Color panel when you do it. And what's also nice is the doctor from Color signs it. And then you put the doctor you want to find out, want to learn about it with you. And then you just have to fill out a survey every 6 months, and your doctor sends in the information every 6 months, and we send reminders. And then you get free information on the website. You get updates by newsletters. You get personal webinars. You can ask questions. There's a navigator. Right now, her name's Natalie. She's great. And so it's just nice to have extra friends and navigators to help you through this process.
Yeah, wonderful. My next question is, we actually have received this from an attendee or someone who registered, but I think we can expand on it a little bit, just talking about a bit more about hereditary cancer and about early detection and screening for prostate cancer. And I think there are some questions on when that should begin based on your family history, maybe based on your race, your veteran status. So let's talk just for a moment about prostate cancer screening, especially if someone has a history of cancer in their family.
So I met a patient the other day that had 5 brothers with prostate cancer, and no one had done any genetic screening on him. And I was in shock. He had a BRCA2 mutation. I was about to bet $1. I don't bet, but I was going to bet him $1. He had it. So you said them, Shelby. So veterans, African Americans, family history, those are people that should be screened early and often, right? We know the rates of inherited and somatic mutations go up with metastatic disease. And we know active surveillance is lower, but still there are risk factors. And if you have one of those risk factors, you probably still should be screened. And right now, insurance does not always pay for that because there's no actionable mutation. There's no treatment indication. And so they're like, why should we pay for it now when it doesn't make a difference? And I say it does for what we call cascade testing. What about your kids? What about your siblings? Right? And, what about your risk? So I think everybody should know their genes.
Yep. Yeah, great.
That's one of the benefits of having an FDA approved test as well. The BRCA CDX, it's a little bit, it's looked at a little bit differently, I should say, from the insurance standpoint. And so we have nearly 100% coverage as far as Medicare is concerned, as far as, private insurance is concerned. And that's for anybody with Gleason 6 all the way up to metastatic. And so these are, widely covered nowadays. Yeah.
Yeah, that's great news. Definitely one of the most common questions that we hear at Xero is it covered across the board, but specifically for genetic testing. So that's great news. Well, you both mentioned a little bit of metastatic disease, advanced disease, and I think we've covered what the results could mean if a patient does have metastatic disease, and what the results could imply for treatment. But let's talk just a little bit more about a patient who either has advanced or metastatic prostate cancer, and what that person should consider when we're thinking about genetic testing.
Well, I think that somebody with metastatic disease should get both germline and somatic genetic testing. Germline will tell you again what you've inherited from mom and dad that could make you eligible for one of these PARP inhibitors or some of the other targeted drugs. But there's also the genetics of the tumor itself, which are going to be overlapping but different than germline testing. And so it's sort of, looking at both will help you understand whether or not you could be eligible for one of these targeted drugs.
Absolutely. Every patient that walks in my door gets both, as long as I can find a way to measure it.
Great. You've both mentioned targeted therapy. So let's talk a little bit. PARP inhibitors are the more recent hot topic targeted treatment. So Dr. Paller, could you talk a little bit about those targeted therapies, and specifically how PARP inhibitors work?
Sure. So the BRCA gene is one of the genes that protects us from developing cancer. It's involved in double-stranded breaks, and the PARP inhibitor attacks those cells where they're weak and inhibits that process even further, and then the cells spontaneously die. And so it's sort of a synergistic effect of the actual gene itself with the drug causes a weakness that we call synthetic lethality, and the cells die. And so there are a few of them. So for PARP inhibitors that you asked about, because there's another one, immune therapy, but the two most common ones are olaparib and rucaparib. And, they're both used in other tumor types, like ovarian cancer and some in breast, some pancreas. And my go-to has always been olaparib, but I had a 92-year-old the other day, or actually 2 years ago, who was on hospice. And I said, let me do one thing. Your family history is very suspicious. And he was BRCA2 positive. And so he had a Lazarus effect, and he went from insisting on hospice to, playing bridge with his friends every week on olaparib. But he started it and he's like, Channing, I can't do this anymore. And I'm like, why? He's like, I can't swallow these pills. My swallowing isn't as good at 92 as it used to be. I'm like, oh. And so I talked to my clinical pharmacist, and she's like, rucaparib's smaller. I was like, okay, we'll try it. And so, there's subtle differences between them. They're all very good. One causes a little less nausea. They're all very similar. But rucaparib's actually smaller. And my 92-year-old always wants me to tell you guys this when I'm on this podcast.
No, I love that. It's so clear that your work and Rob's work is half art, half science. No, that's wonderful. So Rob, this question is for you. I think you've seen this, you probably both have, but how difficult it is to talk about health history and medical history, and with anyone, friends or family. But any tips that you could offer to patients on how to talk to their family, especially when they have now advanced disease or the BRCA mutation? Do you have any tips or pieces of advice that you could give to patients who might be struggling to find a good time or find a good way to have those conversations?
What I always say is that there's any time that you can have this conversation with your family is great. The Surgeon General has made Thanksgiving Day the Know Your Family History Day, because everybody's around the Thanksgiving Day table. But, I had to get a job at a major cancer hospital before my mother told me that a grandfather had stomach cancer. And so it's just something that people don't talk about. And it's just so important to know our family history of everything, not just cancer, because that's knowledge is power. I know that that's a cliche, but it's really true, because that's the only way that we can combat some of these things in our family history, is by talking about them.
Yeah, absolutely. I met a woman, just meet like this, like we're meeting here, but her story really stuck with me. And she was an older woman, probably in her upper 80s, and she said 4 of her uncles passed away, and they just died, and a couple of years went on, and then another got sick and died, and they didn't find out until the 4th uncle had passed away that each of them had prostate cancer. And she and her cousins were at the after funeral reception and eating a meal together and sharing stories, and they had to make a pact amongst themselves that said, we will stop this cycle, and we will start having these conversations with our family because it has to end. So those stories are very jarring and stick with us, I think. Well, wonderful. We're starting to get some questions that are coming in from our listeners. One question, and I know, Rob, you and I have talked about this in a previous event, so I would love to just pepper you with this one again. How do these types of tests, the tests that are used in Promise and the tests that are used at Myriad, you probably already know where I'm going with this.
I do, yes.
How are these different from those types of tests that are like direct to consumer, the 23andMe, those types of tests that are starting to become Christmas gifts and fun conversation pieces?
Yeah, so some of us in the field of genetics call those recreational tests. They're fun, to find out that you're, 17% Neanderthal, is great at parties. But, that's not really going to help your medical decision making. And so it's really important to distinguish. I'm not saying don't do those things, do those things and find out that you're from, Ireland and go, take a family trip or whatever. But those really just need to be held separately than some of the medical grade tests that are available out there.
Yeah, it's not going to help me treat you. So
no,
you can do it for fun,
but it will help you have a lovely conversation.
If you have wet earwax, that's not going to change your treatment of prostate cancer.
Yeah, no, wonderful. Thank you. Are there any, has there been a health equity lens applied to the Promise study? Are you looking for a particular number of Black men in enrollment? I think this question is specifically about how the results of Promise might impact Black men specifically. We know the rates are higher in Black men. We know the mortality rates are higher. Anything that is being examined there?
Absolutely. So my mentor said the other day, he had a patient come in and say, I can't do Promise. It's not for me. I'm not Black. And I said, that's wonderful, right? Because there are groups that are focused on saying, hey, it's for you. And whoever you is in your community, whether it's your barbershop or your church or your radio station, right? It's for you. And so, yes, there are concerted efforts. Funding organizations are working around this great opportunity to go into the community in, places that need more resource support. Whether, it's African-American communities that need some more support and don't have insurance, or if it's veterans or whoever, we are reaching out to those communities. And it's been amazing how people have really amplified the Promise Registry and sort of used it to really reach out in a health equity fashion to communities of need, right? I don't want it that just rich people with babysitting can come to an academic center and get sequenced and go on a clinical trial. That's not okay. I want people who don't even know I exist to hear about it and get tested and get the same genetic counseling that someone else gets going to one of the top academic centers. And so, yes, that absolutely was a focus of ours, and we are actively trying to recruit African Americans.
Wonderful. This is a question from a patient just asking, I lost it. Sorry. Here it is. Tell us, do we know anything more? Has there been any progress made in understanding the Czech II mutation in prostate cancer?
Oh, Rob.
I mean, we're constantly looking at, these genes and trying to decide whether or not they increase the risk for prostate cancer, whether they increase the risk for it to be a more aggressive prostate cancer. The latest that I have seen is that there's no link for increased risk of prostate cancer, but we do know that it is one of the 4 genes that we see most often in metastatic disease. And so it's definitely important. It probably, and again, this is just me off the cuff, this is not literature, but it probably makes the prostate cancer a little bit more aggressive. But certainly it's important, and it's part of every prostate cancer gene panel out there.
Yeah, I think that was a wonderful answer. It's involved in, checkpoint kinase and cell cycle. And so it's clearly important. And I see it a lot of my patients, but that's one of the things that hopefully Promise can help figure out if we follow those men over time.
Yeah, absolutely. This question isn't exactly pertaining to genetic testing, but this patient's wondering, he's a 12-year survivor with a complete prostatectomy, and just wondering about monitoring. Is there anything else that can be done besides quarterly PSA blood tests?
I always say there's 3 rules to hang out with me. And one is how you feel. That is the most important thing, right? Like, are you still exercising? Are you suddenly popping Tylenol or ibuprofen, Advil, right? So feel well, be able to eat well, exercise well, right? That's the first thing. The second thing is, what do your labs show, every 3 months, right? And I don't just look at PSA. I say, how is your kidney doing? How is your liver doing? Kidneys doing? How is your liver doing, right? How's your bone marrow doing? And making sure all those, how's your sugar, right? So the whole being needs to stay healthy. And if both of those are behaving, usually you're good. But if either of those are not behaving, then you need to image. And so that's the third thing. So imaging at different intervals, if there's a question or if you're monitoring for disease recurrence, is always a good idea.
Great, thank you. The next question is just a general question about other identified genes. We mentioned the Czech II, BRCA1 and 2 common, and then the ATM, I think a lot of us are familiar with. Are there others that you're starting to see come up in those results that, even if there's not a next step associated with that, what are some of the other common ones? And I'll also say, I know that you both list them on the websites that we've dropped into the chat. If you aren't able to keep up with this answer, they are both on the Promise website and Myriad website too.
So I think this is one of the most exciting areas of genetics because, back in the day when we had lesser technology, we only did a couple of genes at a time. And if they were negative, we would move on to another couple of genes. Now we have technology that we can look at a lot of genes at the same time. And so, even limiting it to a prostate cancer panel or a breast cancer panel, I think is too limiting, because we are seeing prostate cancer patients who have mutations in what we traditionally thought were colon cancer genes, and traditionally thought were just involved with ovarian cancer, and so it's really important, again, to be tested for all these genes, but also to get involved in research, because that's the only way that we're going to find out that, for instance, BARD1 gene mutations do increase the risk for prostate cancer. I made that up. That's not in the literature, but just sort of that's how we're going to learn more about these genes, and that they may be involved with more types of cancer.
Yeah, I mean, I have a lot of patients with MUTYH mutations that were traditionally thought of as colon cancer, and I'm like, this is really common. We should look at this. The other one that's I always feel like I win the lottery when we get this, is all of the MLH1, MSH2, sort of the panel that makes you eligible for immunotherapy. Right? So I have trials, right? So without hormone therapy, I can put you into remission and just give you immunotherapy, and you have a wonderful life and tell me about all your vacations, right? So it's like the PARP inhibitors, olaparib and rucaparib, there's, nivolumab, pembrolizumab. And so when you have one of those genes, we have another option available for you to control your cancer. And the immunotherapy is being spread to other genes as well, but that's sort of the FDA approved one. That's what we should talk about here.
Yeah, we're learning so much from other cancers' successes. So it's it's great to see. I have a couple of questions coming in around family members, and we've touched on this, but I think it's worth reiterating the risk that a prostate cancer's daughter might have, and what that means, what that might mean for the daughter. And I think on the flip side, what it might mean for a male who was whose father died of prostate cancer, and what that risk means for them. So could you both share, or one or the other, I don't have a preference here, on what those numbers look like and lead us to believe for daughters and for sons and for fathers?
Sure. So we get half of our DNA from our mom and half of our DNA from our father. And so if somebody has a gene mutation, there's a 50-50 chance that they will pass it on to each of their children. There's also a 50-50 chance that each of their siblings will have the same mutation. And so it's really that easy, knowing that you have a 50-50 chance, and you can go be tested for that specific mutation and see whether you inherited it or not.
I would also say that when I have a BRCA2 mutation in a patient, I remind them, right, that they're at risk for other cancers. I've had, feels like a rash of pancreas cancers, so, in my prostate cancer patients. And, you can have melanoma, you can have prostate, you can have breast. And so you need to check yourself, and you need to check your children. And depending on the gene, that's why it's so important to meet with a genetic counselor. You should know which cancers you should look out for, because it might not just be prostate.
Yeah, and so I will go on to say that, there are some patients that think that they can only get the breast cancer genes from mom, or, only the dad's side of the family is important if you have prostate cancer. And that's just not true. These are genes that are shared equally by men and women, and passed on equally by mothers and fathers.
Yeah, very good point. I think it's overlooked, especially when we think we're so well educated, and with prostate cancer, we forget some of those pieces. So yeah,
and a lot of physicians do too. I mean, a lot of urologists that I work with are just asking, is there a family history of prostate cancer? And that's not enough.
Yes, that's what they taught me in medical school, but now they teach the whole thing.
Wonderful. And we've touched on this, but we did have a question come in about Promise, and whether or not family history of prostate cancer is a prerequisite for enrollment.
No prerequisite. You are welcome with or without a family history. You want to really figure out what incidence is and what the genes are that are out there in the community.
Wonderful. Are there here's another question, any research studies, offering tumor genomic profiling after a prostatectomy for patients?
Probably for me, are there any studies offering tumor genomic after prostatectomy? I'm sure there are hundreds.
I'm sure there's got to be.
And I'm sure each company is sponsoring 5 in that space. And then some of the researchers are asking questions and probably treating with some drugs either before or after, neoadjuvant or adjuvantly, based on some of those things. So I can even, think of a few. So yes, there definitely are ways that you can learn about them. One, I should add them to the Promise website. Thank you for saying that, for that feedback. And 2, you can probably go on clinicaltrials.gov and look for them if you're looking for one.
Mm-hmm. Yeah, absolutely. Well, I think that we have come to the end of our list of questions, but anything that we didn't cover that either of you would like to share in your day-to-day that you would like our patient community to be informed of?
I would just say that genetics is not scary. It sounds scary, but if you have a mutation, you have it whether you know it or not. And so don't be afraid of doing genetic testing to find out whether you have a mutation or not. It could potentially save lives.
Yeah, and I would sort of second that and say whether you have no mutation or you don't know yet, if you have one, I still would love you to sign up. I'm trying to make it so you don't have to repeat the spit test. I apologize, but right now it's sort of the entry criteria. So if you have a mutation, definitely sign up. If you don't have a mutation or don't know, please join us.
Well, thank you both so much, Rob. Thank you, Dr. Powler, for joining us tonight, spending your evenings with us. I want to thank our sponsors, Myriad Genetics and the Promise Study Registry, for your continued support. Xero loves working with you so much and values your support very, very much.
You guys are wonderful to work with.
Yeah, thanks for having us.
Thank you. Thank you both. And thanks to all of our attendees. Again, if you missed anything in our conversation this evening, this will be recorded and made available on our website. And please let us know what you think about it. And we'll also ask you what kinds of topics you want to hear about in the future. So with that, I will say good evening to everyone, or good afternoon if you're on the West Coast. And thank you again for joining us. And thanks again, Myriad Genetics and Promise Study Registry. Have a good evening.
Have a good evening.
Good night.
Good night.